Hi, welcome to Your Checkup. We are the patient education podcast where we bring conversations from the doctor's office to your ears. On this podcast, we try to bring medicine closer to its patients. I'm Ed Delesky, a family medicine doctor in the Philadelphia area.
And I'm Nicole Aruffo. I'm a nurse.
And we are so excited you were able to join us here again today. So we have a nice episode here lined up for you today, a marriage of both news update and a topic that we cover lots of. But we wouldn't like to move on to our, learning section without first bantering for a little bit. We have live parallel play happening here. Nikki, what are you up to at this exact moment?
We love parallel play. Well, I'm doing a puzzle, a 1,000-piece puzzle of 101 pooping puppies. And I've taken over our dining room table, aka our podcast studio. And I think I've made good progress.
I
started the day after Christmas, and it's now 3 days after Christmas. I didn't really work on it a lot yesterday, though, but yeah, I think we're coming along.
Yeah, you're impressive is all I've got to say about this. I really did not know this about you, that you were so into puzzles. It stresses me out.
Yeah, I like doing them. I don't know. And then I guess I haven't done one in a while. We periodically would have them out at my house growing up. And then my parents had one in the on the coffee table on Christmas that we were working on. Well, I was working on.
You were.
You weren't. You were stressed out about it.
No.
This one's hard, though. But
well, tell us a little bit more about where we acquired and why 101 pooping puppies.
We acquired this. Our friend Chris got this for you. I think it was part of your graduation gift.
Yes, I think it was.
And he got it because he saw it and he thought of us, or thought of Eddie, I guess, because in our downstairs bathroom, we have 4 pictures, black and white artsy pictures of Ollie pooping.
Yeah. It's the best. I love it. And anytime people
it's
come
funny.
over.
Everyone gets a kick out of it.
They do. They do get a kick out of it. Well, early on in our time together, every time he would poop, because Ollie's my first doggy, that every time he would poop, I was like, oh my God, this is so cool. So I would pretty much every time take a picture of it.
Send a picture to me.
Yep. So that's what's going on here. I can't fathom, your strategy is, you have some strategy, right?
A little bit. Well, you do the outside first, which this top I need to spend some more time with, because the sky, something with the sky and the trees and the branches is off and it's not connecting. So I need to look at this more. I'm trying to finish this. Dog is in a tree pooping on a branch. So I'm trying to fix that, but I need to figure out the top part of the frame. And then then you just go from there.
Wow. So that's what's happening there. We also, I guess, kind of transitioning a little bit. Very soon, if not by the time you're listening to this episode, you will see some new artwork that we have from this episode. So our rebrand is from Vantage Design Works. And we know her as our near and dear brother, Vanessa, who plays a very big role in our lives. But for the purposes of the pod, she expanded on the previous design that we had and now made us avatars, and not just us, but also our intern. And
yeah, he looks so cute.
He looks so cute. We are so happy with how things look, and we couldn't be more honored that she would help us. She spent a lot of time working on this. It seems like she really put her heart and effort into helping us out.
Yeah, she gave us a lot. We knew it was going to be good, but she really did a lot.
She did. She she went forth and did resizing. She kept the branding consistent, things that you and I definitely would not have thought of, colors and No, I mean, like, it was incredible. So we hope that you guys enjoy the new branding. And if you have any, graphic design needs, Vantage Design Works. She's on Instagram, and I believe she has a website too, with the aforementioned name, AdvantageDesignWorks.com. But yeah, we know that she makes great stuff. So thank you so much, Vanessa, for helping us expand our image, I guess. Right, Nick?
Yeah.
That's awesome.
Our image is expanded.
I'm super excited to share that with people. While you're working on the thing over there, I have one very important question for you.
Oh my gosh, I know what this is going to be.
What does tiki mean to you?
Tiki means absolutely nothing to me, personally. On a deep personal level, it means nothing.
I really, what I was asking people, so the reason that this came up is because last night was Tiki Christmas. And now I think people probably surmise that I'm obsessed with Mike, which probably is pretty close to the truth. And he had Tiki Christmas last night, an intimate Christmas soiree that had a flavor of Polynesian flair. And, it invited the question, what does Tiki mean to you? And I will explain some of the answers that I heard last night. From one person, I heard that Tiki meant Moana. Which
little Polynesian flair.
But I think this was unintentional because that person, who, just for their sake, will remain nameless, said Moana means family. But I think...
Ohana.
Ohana.
Who said that?
Well... it's someone who I just, I'm not sure if they would be so comfortable with me name dropping them. And I want to respect their privacy. So, but we love them dearly. And Moana may not mean family, but it definitely means Polynesian flair to me, Disney princess wise. Yeah. So I think it fit with what does Tiki mean for you? Then there was Ohana means no one gets left behind, which invited someone to think about, early 2000s educational, or Lilo and Stitch, and early 2000s
means family. Family means nobody gets left behind.
But it also means early 2000s educational incentives or programs from the U.S. government in the George Bush era.
I'm bringing Bush into this.
I am. So that's what Tiki meant to that person. Otherwise, Tiki meant things like elevation or a person, with the Tiki pole. And then a very astute Riley said that, actually gave us the definition of Tiki, which maybe we'll try to provide here for you today. It actually has quite the cultural meaning. So the New Zealand definition is that a Tiki is a large wooden or small green stone image of a human figure. Ollie's very excited. The word Tiki wasn't frequently used as frequently as it was.
Oh my goodness, Ollie.
My goodness, Ollie. So otherwise, in Polynesian culture, the Tiki represents the connection between man and nature, between heaven and earth, and symbolizes creation and life itself.
Oh, really?
Yep. So I definitely felt that last night. He just knew
that off the dome?
No. He gave...
Well, he's also a history teacher, right? Is that what he teaches?
He teaches a lot of AP classes. I heard he teaches AP microeconomics and several other ones too.
Not a history teacher.
I think he also might be a history teacher. That's on me for not finding out enough. He did not know that off the dome. He looked that up. But he also tried his hand at pronunciation of a lot of them. And I credit him for that.
Of a lot of the Tikis?
Well, there's a lot of language and names of a story and involved players in the story that he was, and then, I invited the question, which to some seemed like it was a bold question, of what is your favorite conspiracy theory?
Oh my God.
Now, I wasn't implying that people had to believe the conspiracy theory, but what was your favorite conspiracy theory? And, some people took it to heart. Some people said that there was a flood that, is across multiple religious, writings of the time, and that everyone had this common experience of a flood that ended humanity, if you will. And that the Sahara was one of the main locations for Atlantis and somehow related lore to the flood. Other people said that, the U.S. government and the CIA changed writing post-World War II to be more reflective and less self-critical of U.S. capitalism and related concepts. That was a very insightful one. Another person said that Michael Jordan was forced to retire instead of choosing to retire because of his gambling problems. But, our personal favorite conspiracy theory, which is more of a playful one. Nikki, can you tell us what our favorite conspiracy theory is?
Our favorite one is that when we leave the house, Ollie stays home and he does experiments.
Yes. And that leads to his Professor Oliver Jones, PhD. Actually, no. Professor Oliver Cheese Jones Aruffo, PhD extraordinaire. We're still waiting to see the scientific journals of his experiments, but
well, he can't let all of his secrets out,
Yeah, and that's and then he goes right back to normal when.
Well, remember that time
we return? Oh, there was something that happened.
Okay, so there's like a light fixture in our kitchen, and there are 3 light bulbs on it, and one of them was out.
Yes,
and we left to go do something one night to go to dinner or something, and we came back, while we were out. We leave and we're like, all right, Ollie, have fun. You're doing your experiments. And one of us was like, wouldn't it be so funny if Ollie's just at home changing the light bulb? And then we came home and all 3 light bulbs were on.
Yeah.
And then we just looked at each other and looked at him.
He's licking his chops. And he's hi guys, I'm back. You're back.
Nothing to see here.
I love those. That's my favorite. That's my favorite conspiracy theory. We'll keep it there. Let's see what else I've got.
Conspiracy theories are a crazy thing though, because I feel like it just goes to show if you really try to explain something and convince someone of something, you can make them think that it's real.
Yeah.
And you can be as delusional as you want, and you can make someone think whatever. If someone sat me down, a flat earther sat me down and was these are all the reasons, you could probably convince me that the earth was flat. I know the earth is not flat.
Right.
But you can make a good argument out of anything,
Exactly.
There was a good argument that we never landed on the moon, which I'm still a little bit 60-40 on.
60-40?
Maybe 70-30. I could be very convinced that whole thing was fake. Namely because of the whole live streaming of it. Netflix couldn't do a Love is Blind reunion live stream.
Good point.
Live. But you're telling me they could do that in
the 60s.
The 60s. When was that? Yeah. I can't get a good signal sometimes on my cell phone when we're sitting on the beach. But you could have streamed this to everyone in the world.
That's a good point.
60 years ago?
Yeah. I mean, is it possible they took a video and they called it a live stream?
Maybe.
And let alone live streaming from Earth. Talking about live streaming from the moon.
That's what I'm saying.
I think we have to be a little careful here because that we're going to start sounding like
no, I'm just saying
anti-moon landing.
I'm not anti. I'm just saying I could be convinced that it didn't happen. The more you think about it or something, and then you're wait a second. These conspiracy theorists could make a point, could make a convincing point. But are they just making a point to try to make a point,
Yeah. I think maybe we have to put away the tinfoil hat for now and keep thinking about what we're up to. So, wow, as luck would have it, we are 14 minutes in. Why don't we get started? Are you ready to get started? Or
I'm ready to get started.
Great. So, what are we going to talk about today, Nick?
Today, this is going to be very exciting because we're talking about oral Wegovy.
Yes. So this is everywhere in the news. I think a lot of people who have any sort of tangential interest in the GLP1 medicines or weight loss have heard about this. And so my hope here today is to find as we normally do, a balanced middle of the road perspective that's educational about what this actually means for people, how it works, and all other good stuff that you wouldn't gather from just a headline. So you might be thinking like, wait, so now is Wegovy just a pill? Is it the same thing as an injection? Does this mean that the meds got easier? We're going to slow down today and explain what actually got approved, who it's for, how effective it is, and what people should realistically expect. So we're going to try to separate the excitement from more understanding so that we can keep our, unsexy, balanced perspective like we normally have. Seem fair?
I think so.
Cool. So it seems like December is a big time for GLP news because last December, the Zepbound got FDA approved for treatment of sleep apnea, which has been helping a lot of people. And so in this December, the FDA, Food and Drug Administration, approved oral semaglutide or oral Wegovy. So oral semaglutide, 25 milligrams, branded as Wegovy for chronic weight management. And by and large, this is the first oral GLP1 receptor agonist approved specifically for obesity. It is not the first one or only one that will be coming out, but right now it's the first one that's FDA approved and it's expected to hit the market soon. So who it's approved for? These are adults who have a BMI of greater than 30, having class 1 obesity or higher, or a BMI of 27 with at least one weight-related complication. And I thought this is very interesting because these are very, very common. So someone with a BMI of 27 or greater with high blood pressure. Wow, what a common thing we talk about and how many people would benefit. There's a whole lot of mechanistic reasons that would explain why some weight loss would help someone's blood pressure that maybe we'll save for a different episode. 27 or greater and type 2 diabetes. 27 greater BMI and cholesterol issues. 27 or greater and sleep apnea. And 27 or greater and cardiovascular disease. These are the groups that this medicine is approved for. So there's an important distinction that I want to say is that Rybelsus is also oral semaglutide, and this has been out for a while. And these doses, it's for diabetes is what Rybelsus is for. And so it's not designed to have any weight loss, meaning that the doses are not up to snuff in that case. So Rybelsus is different in the way that it has 7 milligrams and 14 milligram doses. You probably remember earlier from just a couple seconds ago when I told you that oral Wegovy is approved for a 25 milligram tablet. What seems to have borne out in the trials that they looked at this is that higher doses, like 50 milligrams, work very well, but are not quite ready for prime time for FDA approval. And so 25 milligrams is the top dose currently FDA approved, while 50 milligrams of Wegovy, oral Wegovy, has been evaluated and is still under consideration, but not approval yet. Other FDA indications for oral Wegovy, it would include reduction in major adverse cardiovascular events, that means heart attack and stroke, in people with obesity, and established heart disease. So if you've had a heart attack or a stroke, which is a lot of people, you're a person that this could benefit. In truth, we've had lots of data. This is not something we've done a whole episode on, but we've talked about in passing, is that these medicines reduce the risk of heart attack and stroke in people with obesity. And also FDA indications for metabolic associated steatohepatitis, which is a later stage form of metabolic associated dysfunction, the fatty liver, essentially. How that would be discovered is with fibrosis with F2 or F3, which is an indication that is a thing that comes from the imaging study, the ultrasound imaging study that can help describe the fatty liver. You are really cooking at that puzzle over there.
Yeah, I am. Sorry.
No,
you're just cooking on
I'm just cooking.
The education.
I am. So it turns out that the one bottom line is that not all semaglutide pills, the Rybelsus versus oral Wegovy, they're not interchangeable because the doses aren't the same. And currently only one specific dose is approved for the weight loss. Does that make sense?
I think so.
Did that sound okay to you over there?
Great.
Cool. So the concepts, let's go back and venture into how oral semaglutide works without trying to get too bogged down into my one of my first loves educationally, biochemistry. So the big idea is that it's the same biology as the injectable ones, but it's a different delivery system. Semaglutide mimics GLP1, a hormone that's involved in appetite regulation, satiety, which is a sensation of fullness, and glucose metabolism. There are central effects that people notice. The central effects being ones that affect your brain and your body's communication with hunger. So the central effects are reduced hunger, feeling full faster, and something that's been very described as less food noise. The peripheral effects, these are effects that are happening outside of the brain on the body, are, for at least a small period of time, slower stomach emptying, which we've talked about and why it's prudent to eat slower, eat half your portion size. Increased insulin when glucose is high, meaning that there is more insulin sensitivity. Glucose can be used more effectively, and lower glucagon release. So, these were made injectable for a while, and it was that's the expensive part. So the concept of a pill coming around makes this more accessible for sure. But for our purposes, what makes the pill possible? And it's combined with an absorption enhancer that allows a peptide drug to survive the GI tract. When you deliver a medicine right under the skin into the subcutaneous tissue, which is the skin underneath the tissue underneath the skin, it's a little bit easier, honestly, to deliver medicine. The GI system can be harsh. You have to go through an acidic stomach. You have to go through the rest of it, and then you have to go through the liver and be processed by the liver oftentimes. So you'll notice that Wegovy, semaglutide, 25 milligrams, is way higher than the injectable dose, the top injectable dose, which is 2.4 milligrams. So food for thought. That's also why when you take it matters. And so this is a very important part. These are some administration rules. And I really want to bold, underline, emphasize that for when people start taking these, you have to take it on an empty stomach. You should take it with no more than half a glass of water is their current direction. And at least 30 minutes before food, drinks, or other medications. And so this is very important. It's a little unique. It's not a medicine that you can take at any time of day. It's not one you can take as needed. So, the trade-off for the once weekly injectable medicine is that you have to be pretty particular about how and when you take this medicine. It works very well, but only if it's absorbed properly. And so if you don't adhere to these, you will probably notice that it might not be working as well as it could be. So that's how or why it's a little different. The third section I want to talk about is how effective it is. I think people care a lot about this, so I will take us through these. A series of trials done under the name OASIS, OASIS. And OASIS 4 is the FDA approval trial at the 25 milligram dose. What they discovered is that there was an average weight loss of 13.6% over 64 weeks. And this is compared to the placebo group, who got 2.2%. And something that gets tucked away in there is that everyone in these trials were doing diet and lifestyle changes. So the people in the placebo group were taking a sugar pill or something, and they were doing diet and exercise changes, just like the people in the oral Wegovy group, which is not I don't think that's emphasized enough, because I think people were probably just going through their average day, or the concept is people think people in these trials are going through their average day and they're just adding the medicine, but it's technically two interventions. It's the diet and exercise and the medicine. So just keep that in mind. Another interesting result is that nearly 1 in 3 people lost 20% or more of their total body weight. And overall,
that's a lot.
It is a lot. So they also look at what's called categorical weight loss, which is weight loss of populations of people, like what percentage of person lost this. It's like how many people lost 5% of their body weight? How many people lost 10% of their body weight, 15, 20, so on and so forth. And the reason that this is important is because we know at those thresholds, people start to have metabolic benefits. At different thresholds, maybe we'll talk, this is a whole episode in and of itself, I think, but at different thresholds, people, their diabetes improves, their insulin resistance improves, blood pressure improves, sleep apnea improves at different thresholds, 5, 10, 15, 20, so on and so forth. Oh, good. So I did find for the oral semaglutide, I found at 64 weeks that 79, this is the categorical weight loss from the study. So for the percentage of participants on oral semaglutide, 79.2% of them lost greater than 5% of their total body weight. That is pretty much 8 out of 10 people. 63% lost 10% of their total body weight, which is a like very distinct clinical meaningful outcome. Losing 10% of your total body weight will do a world of difference. Half of them lost 15% of their total body weight, and 29% lost greater than 20% of their total body weight. So I thought that was a very interesting thing. This is it's already better than all of the other. It's already better than the naltrexone bupropion combinations and phentermine topiramate combinations that have been used prior to this for oral medications. So it very, very effective. Any thoughts so far on any of that?
No, I think it sounds great.
So then they also looked at the higher dose trials, and this is not yet approved, but important for context. So Oasis 1, I just spent all that time talking about Oasis 4, but there were other ones to get there. Oasis 1 was evaluating the 50 milligram dose. And in that one, the mean weight loss was 15.1%. In this case, 85% lost at least 5% and 34% lost 20% or more. I do think that they reported there were more side effects in that trial for maybe what's a marginal improvement in total body weight loss. And that's maybe why 50 milligrams is not the go-to dose right now. And then something that we should spend more time about, but we'll discuss here, is the Oasis 2 trial, in which they exclusively looked at East Asian populations of people. Something that I'm here to tell you is that people of East Asian and Southeast Asian descent have increased risk of metabolic disease at lower body weights. I don't understand why at this point, and I'm not exclusively sure if many people do. I'd be happy to learn more about it for you guys, but it's just a fact. And so in Oasis 2, they looked at this specific population of people. And also of note, like if you're listening to this and this is you, like you people of East Asian descent qualify for these medicines at lower BMI ranges because BMI cutoffs are not the same. Like for the average person here living in New Jersey, like the BMI, and maybe they're Caucasian or African American, what have you, their BMI cutoff for class 1 obesity is 30. For someone of East Asian descent, it could be 27.5. I have seen some guidelines suggest 25 as a cutoff.
Wow.
Yeah. So it is very significantly different for these people. And when they looked at oral semaglutide for people of East Asian population descent, that they found the overall total body weight loss to be 14.3% sustained over the timeline, I believe 64 weeks. And people with diabetes lost 10.7%, which is also an anomaly that we see, that people who have diabetes tend to lose less weight on these medicines overall. So the show's effectiveness across different populations is one takeaway, and that hopefully you learned today that these populations of people are a little more vulnerable to metabolic disease. So a key takeaway that I want you to remember is that maybe oral semaglutide at a higher dose matches the injectable semaglutide, and it isn't just a weaker option just because it's oral. So the next section we want to talk about is side effects and safety, to set some expectations honestly. The most common side effects, which seemed to be very similar to injections, well, I'll put it to you this way. The style of side effects was very similar. The proportion of side effects experienced was more. Types of side effects include nausea, vomiting, diarrhea and constipation, and abdominal discomfort. And the question is, how common did these happen? Probably more than people would like to hear. it turns out that about 3 out of 4 people reported GI symptoms at some point. The number of people that discontinued the medicines because of the GI symptoms was much less. However, you would expect to experience something. I would be more surprised if you didn't, seeing 3 out of 4. All that to say, most of the side effects are mild to moderate, they're temporary, and they are worst during dose increases or initiation of the medicine. More serious but uncommon risks include gallbladder issues and more specifically cholelithiasis. This is the medical term for gallstones. That is not a feature of the medicine. It is a feature of the pretty rapid weight loss that happens when people are on them. So if you have too rapid of weight loss, because this is also seen in bariatric surgery, if you have too rapid weight loss, you can precipitate gallstones. Rarely you can see pancreatitis. I think this more affects people who've had a previous history of pancreatitis. This came out when the medicines were first coming to market. It was in the trials, and then real-world data suggests that maybe there is less pancreatitis than we initially thought. And additionally, there is a very low risk of hypoglycemia unless it's combined with insulins or medicines called sulfonylurea. I'm thinking one coming to mind is glimepiride or glipizide. These are very commonly medicines used previously in diabetes care. What we also saw is that large reviews showed that there was no meaningful increase in major cardiovascular events. We actually have data that it decreased cardiovascular events. There was no increase in mortality, which is great. We saw it actually decrease mortality, and there was no meaningful increase in cancer. And so this is all very important because safety first. First, do no harm. These meds are powerful and they're not dangerous when they're used appropriately. Does that seem reasonable so far?
I think so.
Cool. So people who should think about not taking oral Wegovy, the absolute do not pass go, what's called a contraindication, a thing you have that you can't take it for, is a personal or family history of medullary thyroid cancer, a rare endocrine disorder called multiple endocrine neoplasia type 2, if one is pregnant or breastfeeding, and there's whole strategies that could be had around like being a woman who might get pregnant soon and being on these medicines beforehand. And then second thoughts about people who have severe allergy to semaglutide, of course, and its purpose in type 1 diabetes remains inquisitive because sometimes people have multiple components going on, including insulin resistance and type 1 diabetes. These medicines should be used in caution, or you should be used with caution in people who have a prior history of pancreatitis, severe gastroparesis, already known gallbladder disease, and active suicidal ideation. What's also important to recognize is that these should not be combined with other GLP1s or medicines called DPP4 inhibitors, which are also very commonly prescribed for diabetes. So that's a list of people who should think twice if they're taking this. Sound reasonable so far?
Mm-hmm.
Cool. So then we've been preaching this for a while, but then getting back to section 6 is the long-term reality, is that this is a chronic treatment because treatment of obesity as a chronic disease involves chronic treatment with changes in lifestyle, medicines, and sometimes surgery. And so the weight loss is maintained while on therapy. And what they discovered is that when people stop, they can regain up to 6 or 11% of the lost weight within a year. I've also seen other data that suggests that people, after the course of time, can regain back to 2/3 of their total body weight that was previously lost, which makes sense to me. If you stop taking your blood pressure medicine, your blood pressure would go up. If you stop taking your cholesterol medicine, your cholesterol would go up. So, nitty gritty, practical use, how patients actually take it. This stuff is exciting. So there's a dosing and titration protocol. The idea is to start low and go slow. So the first usual starting dose is often 3 milligrams. The idea, similar to the injectables, is to increase it about every 4 weeks. And so the titration protocol may look like 3 to 7 to 14 to 25. And if one needs, a slower titration protocol may lead to fewer side effects. Just some quick tips that can really help. Eating smaller meals, avoiding very fatty foods early on, staying hydrated, treating constipation early, and short-term nausea meds if needed. Does that seem pretty clear? Mm-hmm. You were just churning and burning on that puzzle over there.
I am. Did you see this whole part I got?
Oh my gosh.
Right here?
No. I think this is so cute. I love how like genuinely interested you are in this. All right. So now time for cost, insurance, and access. And this is always the hard part with these medicines in this day and age. The annual list price of this medicine, which is usually not what people pay, but the annual list price is $14,000. Sometimes with people with coupons can pay $7,000 to $8,000 in the year. And it turns out that only about 25% of people get coverage for these medicines available. So
that's lame.
It is lame. So why this matters, the high costs lead to high rates of discontinuation. And this disproportionately affects people who have lower incomes, which is unjust. So one important warning that I have, we have a whole episode about this, is to, in the event of them being more expensive, what has come about is compounding pharmacies and compounding GLP1s. And the tough part about these is that they are unregulated. They are discouraged by the FDA because there is data that people can suffer more harms because of the unregulated nature of them, meaning that like there could be more medicine in the compounded version than you anticipated, or a quiet harm of less medicine and not getting the actual benefit what you're paying for. And overall, they are not equivalent in safety or reliability to the standard preparations from the companies that make these. The other last piece on cost that I'll say is that, practically speaking, I've seen a number of $150 for the starting dose tossed out in the news. And my 2 cents are that I do believe it will probably be more expensive than that. If the starting dose is 3 milligrams, you do the math in your head, 3 milligrams all the way up to 25 milligrams. It will probably be more expensive than $150 a month. And I also realize that it will probably fall somewhere under the current thresholds, which are around 250 to 300 to 350 for the ranges of the injectable Wegovy. So I don't know what the pricing will be. No one knows yet. And by the time someone listens to this months later, the information will be out. But when we're recording this, we don't know at this time. So I have done a lot of talking, and I think what I want to do is kind of wrap things up. So oral Wegovy is a real advance, and I think we're all really excited for this. I think it's going to improve access quite a bit in the course of time. It keeps pushing obesity medicine forward as a priority for so many people. This really helps for people who don't want injections. It's effective, it's evidence-based, and it treats obesity the way we treat other chronic diseases, which may change the conversation or change what people or how people think about it. But overall, it still requires the right patient. It does require long-term use. It requires all of the beautiful lifestyle changes that happen in between your injection or in between the moment you take that pill, the moment-to-moment changes, the healthy choices you make every day in your life. And, the honest conversations about these are expensive. They're tough to get right now. Hopefully one day that changes, but that's the reality right now. And if you're hearing this and you're wondering whether this might be right for you, it's actually a terrific conversation to have with your doctor. And now you have a little bit more information to be informed and be a part of that discussion. And that's what I got for you guys today. Any takeaway thoughts?
Well, more people might be more inclined to take this versus doing an injection,
Yeah, because we've talked about that. It's like common to think about taking oral medicines. And even if you think about like now, this one medicine might be able to replace your blood pressure pills, this is me speaking from a couple experiences that I've seen, but like if you lose weight from these medicines in a way that you've tried before, and like 10, 15% of your total body weight, which is within the realm of possibility for these medicines, your blood pressure gets better, your cholesterol gets better, your blood sugar gets better, all from one medicine.
Sounds like a nice nice deal to me.
It does. It does sound like a nice deal. So I'm hopeful and will be keeping my ear to the ground for more information to share with you all. But mostly, thank you for coming back to another episode of Your Checkup. Hopefully, you were able to learn something for yourself, a loved one, or
a neighbor.
Check out our new graphics. We're so excited about them. Thank you, Vantage Design Works. And check out our website, Your Checkup Podcast at, actually, you can send us an email, yourcheckuppod@gmail.com. Check out our website. You can find us on Instagram. Share us with a friend or a neighbor. But most importantly, stay healthy, my friends. Until next time, I'm Ed Delesky.
I'm Nicole Aruffo.
Thank you and goodbye.
Bye.
This information may provide a brief overview of diagnosis, treatment, and medications. It's not exhaustive and is a tool to help you understand potential options about your health. It doesn't cover all details about conditions, treatments, or medications for a specific person. This is not medical advice or an attempt to substitute medical advice. You should contact a healthcare provider for personalized guidance based on your unique circumstances. We explicitly disclaim any liability relating to the information given or its use. This content doesn't endorse any treatments or medications for a specific patient. Always talk to your healthcare provider for a complete information tailored to you. In short, I'm not your doctor.
I am not your nurse.
And make sure you go get your own checkup with your own personal doctor.